my original title was What Next? Pandemic Influenza, What Next? And I realized that predicting the future is much harder than talking about the past, so I will talk about the past, but I hope to I also chose this topic because, as many of you will have read, there's a lot of controversy right now about sort of 1 year later, what have we learned from the pandemic response? Was it overblown? Was it, some have even argued, a conspiracy by the drug companies and their hired guns to exaggerate the threat? And on the other hand, there are a lot of people in public health who are spending their time trying to continue to understand and monitor this threat, and who obviously do consider it a serious thing. And one of the real lessons of this pandemic for people who work on it, and who work in flu in general, is the surprising difficulty that many of us experienced figuring out how bad this was going to be, how bad it was, how bad it might be. And so I want to give you some perspective on that experience, and then I hope engage many of you in a discussion toward the end of the question of, had we had perfect knowledge at various stages, what would we have done differently, if anything? How do you make an appropriate decision about the scale of response in the face of a threat that's uncertain? And what if anything, can we learn for the future about designing an appropriate response to a pandemic or another event? Let me close the door. So I spent about a week at the end of April, beginning of May at the CDC, along with some other epidemiologists from outside the CDC, and an awful lot of people, hundreds of people from within the CDC, working on trying to understand what the threat was, what this pandemic really was, and what the appropriate sorts of responses would be. And a number of us, all of us sort of academics from various places, wrote a short paper that we published in May that set out what I think is still the problem, which is that lots of decisions have to be made, often within weeks of discovering that there's a problem. And the data to make those decisions, the data you would like in order to make those decisions, trail by many weeks to months the need for the decisions. And so you try to make decisions based on evidence, but there's always a lot of uncertainty implicit in that evidence. And so I want to talk to you a little bit about where that uncertainty comes from, and why the decisions are hard to make. So I'm going to focus on severity. There are a lot of other things you want to know about a pandemic as it's emerging. You want to know its virologic characteristics. You want to know its drug resistance. You want to, if it's drug resistant, you want to know what sorts of people are getting it. And we'll talk a little bit about some of those topics. But the really fundamental question, as defined in advance by our pandemic planning, is how bad is the disease? What's the chance that you get it, and that someone will get it over the course of the whole pandemic? And what's the chance that you die if you do get it? So very simple concepts, but as it turned out, difficult to estimate. The main reason it was difficult to estimate is that you don't ever measure every case of flu. People's pathology from being infected with flu, even a pandemic strain, can range from almost no or no symptoms to very subclinical symptoms that may make them ill, but they don't seek medical attention, to symptoms that send them to the doctor and a few days later they're better, to hospitalization and worse than that. And it's easy to find some of the people who end up in hospital. You don't always know that they're in hospital because they have the flu. It's hard to find the people who don't seek medical attention. It's sometimes easy and sometimes hard to find the people who are not too sick but do seek medical attention. And in the middle of a new event, the response basically geared up around the last week of April. So by late April and early May, there was lots of data coming in, and exactly what it meant was the issue. This is a plot on the left side here of the growth in new cases from the line list, which is the list that CDC kept of all their reports from the states of confirmed and probable cases of H1N1 flu. And this is a log scale, and so you can see that there's exponential growth, meaning a linear increase on the log scale in the number of new cases happening every day. That then tails off basically because it takes time to get cases reported. So this tailing off is not that the epidemic was going down or even that it was getting harder to measure, but rather just this is the delays up to May 13th in the reporting. So you have exponential growth of cases, and some of that is because when a new disease enters a population, it grows exponentially. Each person infects, say, 1.5 others on average, which is probably about what it was for this virus. Then those infect another 1.5 on average, and so you get exponential growth. But there were also changes in reporting, even at this very early time, as people became more aware of the disease, started testing more people, public health operations started gearing up. People were diverted from working on gonorrhea or tuberculosis or whatever they did in public health, or heat injury, heat stroke was a popular thing to divert people from, and beach accidents to working on flu. Whatever people were doing, they were diverted from in public health departments, local, state, and beyond, federal and beyond. And so the detection is gearing up. And one way that we could measure this detection in the line list was by looking over time, over this same period of time, the fraction of the detected cases who were hospitalized. Because the better the ascertainment, the more you're noticing and testing and verifying the relatively mild cases, the lower the fraction of hospitalized. So when it's high, it means you're just seeing the very sickest. And as time progressed, people began testing. There were more nurses available to do the testing, more testing facilities, and you can see improving ascertainment of mild cases. And that was getting about 10% per day, improving by about 10% per day, which is quite a dramatic contribution to this growing number of cases. So partly the disease was spreading, and partly we were just being able to measure it better. Why does this matter? Well, of course, if you want to know how severe it is, what's the chance that if you're infected, then that you're going to die from it, as one very simple measure of severity, you have to know how many people are infected. And we never actually knew that during this period. We knew how many people were being detected, and among those people, initially about 20% were hospitalized, actually initially about more than 50%, so it was really only the very sick ones. Later on, 20%, and then by the end of April, it was about 2%. So there was better and better ascertainment, but we never knew quite where on the curve we were, and we never had a proper denominator of total number of people infected. And this is a national average, but of course there was variation in space and time. So I told you about time, but space, as each community began to scale up its public health efforts, it probably first tested people in hospitals and then in the community, and that happened differently in different places. If we had plotted this further out, it would have started to come back up again, because with an exponentially growing epidemic, you have a stretchable but essentially fixed number of public health workers and labs to do the testing, and eventually the size of the epidemic gets so big that you again can't measure everybody. And in fact, by the middle of May, most places were changing their testing recommendations and no longer testing mild cases. So this curve would have gone back up again, but that's not shown on this graph. So all of this ascertainment was changing over time. As a result of that, people's estimates of severity were kind of all over the map at the beginning. And here are some of the data that went into that. So in Mexico on May 4th, there were 509 total confirmed cases to date, of whom 19 had died, so that's 4%. For comparison, the worst pandemic flu of all in memory was the 1918, in which about 2% of people who were ill died. So taking these numbers uncritically, you would say that it's twice as bad as the worst pandemic on record. In the US, on the other hand, there were about 1,000 total cases. And please stop me if there are any questions along the way or comments. Only one of whom had died. So that's 1 out of 1,000, or 0.1%, 40-fold lower than Mexico. We knew that there were biases informing both of these numbers. In Mexico, we knew that preferentially the sick people were getting ascertained, because this was the beginning of the epidemic, and well, it wasn't the beginning of the epidemic, it was the beginning of knowledge of the epidemic. It had been spreading for some time. And in fact, we and several other groups estimated eventually that this number was probably 2 to 3 orders of magnitude too low, that they were just getting the very severest cases, and there were probably larger numbers, but we weren't sure of the magnitude of that at the time. And because we were missing mild cases, we knew that these estimates were being pushed in the direction of overestimates. We also knew, though, that there was a risk that we were underestimating for what's known as censoring bias. And this is something that was a very important piece to put up a slide. A very important bias in SARS, so in 2003 when we were trying to estimate severity. Turns out it wasn't a big deal in flu, but we didn't know that at the time. And that's a very simple concept, which is there chalk? Yes. Which is, if you have an epidemic and people are getting infected, and this is the number of people infected, it's growing exponentially. And suppose that you look at this time and you see that there are maybe 1,000 people who you can tell are infected, and suppose that you see that there's 1 death, not to scale. Well, you haven't actually measured all of the deaths in the 1,000 people up to here who have been infected, because it takes people time to die. People don't die the day they get infected, and it takes time for those deaths to get reported. So, in fact, you're really measuring the 1 death out of a denominator that's maybe somewhere back here, if it takes this amount of time, say a couple of weeks, for people to die. So the proper number to divide by, in some sense, is to divide this 1 by how many people were infected at the time when this person who's dying was infected. And you can make that more careful mathematically. But the point is that in a fast-growing epidemic where it takes a long time to die, if you just divide deaths by cases, you get an underestimate. And the faster it's growing and the longer it takes to die, the more you underestimate it. There are ways of dealing with that, but you have to know something about the time to death, how fast it's growing, etc. So we knew that there was this problem and this problem. They biased the estimates in opposite directions, and for that reason, the published estimates in July were all over the map, ranging from a case fatality ratio of about 0.06% down to 0.0004%. And at the same time, a week later, 10 days later, in the British Medical Journal, an estimate of 0.2 to 1.2% focused on this issue of censoring bias, whereas these people focused more on the issue of missing detection of mild cases. So it was confusing. We kept quiet for a while because our group was confused and didn't know what the answer was, but eventually decided to try to make our own estimate of severity in collaboration with a lot of people from a couple of local public health departments in New York and Milwaukee, and colleagues in the UK and Hong Kong. And what we decided to do was to try to estimate this ratio of deaths to symptomatic cases by cobbling together data from different places. New York City had decided not to try to count cases. Very early, they had a big outbreak at St. Francis School that was in the news. It was one of the first big outbreaks. They decided, as soon as that was over, they decided that measuring cases in a city of 8 million people was going to be an overwhelming task, and they weren't going to try to do it. But they did eventually, sort of to their surprise, I recently learned, find that they could count hospitalized cases. They didn't even expect that they could do that, but they did. And they did very intensive testing and efforts to try to find people in the hospital who had flu. And they also counted deaths. And in New York City, because it's a big place and there was a lot of flu, they had about 50 deaths, which is just about enough to do statistics on. But they had no idea of how many people were sick or medically attended or symptomatic. Milwaukee, on the other hand, is a much smaller city, did much more intensive surveillance for medically attended cases. They confirmed about 3,300 cases, which was I don't know that it's a substantial percentage of all the cases confirmed in the United States because they made that decision to test much more extensively. And for them, it was possible to because they looked so hard for medically attended cases, it was possible to get a ratio of hospitalized to medically attended cases from Milwaukee. And finally, CDC had done a number of telephone surveys and other in-person surveys to try to estimate the ratio of all those people who were sick, how many of them sought medical attention. So by putting these three estimates together, it was possible to try to get an estimate of the overall ratio of dead to symptomatic cases, which we call the symptomatic case fatality ratio. This word case fatality ratio is used frequently, and one of the things I think people learn from this epidemic is that it has many different meanings to different people, and you really have to, fatality is pretty well defined. Case is not very well defined and could mean people seen by a physician, as it did in the BMJ article. It could mean symptomatic people, as it did in our article. It could mean people who were infected, whether or not they were sick, and that you would detect by doing serologic tests to see whether they show evidence of a history of infection. And so this terminology is a bit vague. Yeah?
I just don't know what symptomatic means.
That's also vague, so you're right not to know. In this, it depends on who's asking the question again. And there are basically two common definitions of symptomatic. There's influenza-like illness, which is a fever above, I believe, 38 degrees plus a respiratory symptom, cough or sore throat. There's acute respiratory infection, which does not require fever, and where it's clear that a number of people who got the flu, who you could detect the virus in, never had fever, and so that probably should be included. And one of the limitations of this method, and in fact most methods, is that the definition of symptomatic changed from place to place.
There was a time when the CDC stopped collecting case data or numbers. Was it because of the expense of the treatment, or they just knew it was, the percent was so high?
Yeah, so in most places, Milwaukee was a tremendous exception to this. In most places, there just weren't the resources, even putting the entire local public health department on the case to test the majority of mild cases. And a sort of uncertain fraction tested just produces data that's totally uninterpretable. So I think they correctly said, stop doing this, tell us other summary data. It's not a good use of resources. So it's not that if they just had a little more money they could have done it. It's just at some point exponential growth gets bigger than any public health department can stretch to be. So they were, I think it was hard to explain that decision, but it was the only rational thing. And in fact, most places had decided that on their own. We also took an alternate approach for a reason that you'll see in a minute, which was that I said that New York City really measured deaths and hospitalizations well. They also had a phone survey to ask people if they were symptomatic, and they designed the phone survey as it happened to be for a time, I mean this was on purpose, to be for a time which covered the month of where almost all of the spring incidents of flu occurred. So they asked people, did you have fever and some respiratory symptom in the last month? And the time period was exactly chosen right. The epidemic curve was something like this, and they got almost the entire hump of the epidemic curve. So that was good. And as it happened, it was May, so there was very little. May and June. So there's very little other respiratory infection going around that's outside of the season. So we made the assumption for that phone survey data as an extreme case that maybe everybody who said they were symptomatic was symptomatic with flu. There were some issues with that, partly what we just discussed, that not everybody had fever who had the flu, so we were undercounting. There are also issues that people really have no idea, in my opinion, whether they were sick in the last month, based on some other phone survey data, which it's just hard to believe they actually know what they're talking about. I mean, based on the numbers who say yes, and we can go into that later if you want. So this is unreliable, but sort of gave us a rough upper bound on the number of people who might have had swine flu, and therefore lower bound on the severity, the risk of death per case. So these are the results of that analysis, which was published in PLOS Medicine at the end of 2009. If you use the phone survey data, you get relatively lower estimates because you have more people sick and therefore lower chance of dying per sick person. That's on the top. And if you use the combination of New York City and Milwaukee with the survey data on what's the chance that you go to the doctor if you were sick, which is about 50% in the CDC surveys, you get these lower numbers. So lower on the page, higher numbers, larger numbers, lower on the page. So skipping to the case fatality ratio, the ratio of deaths to symptomatic cases, overall, the self-reported flu or influenza-like illness denominator gives a risk of about 1 in 14,000. So for every 14,000 symptomatic cases, there was one death. It's about 7 times higher than that if instead of believing that estimate of how many people were sick, you believe that about twice as many people were sick as those who sought medical attention, consistent with what people say in a different survey. So one reason I say this phone survey must have been wrong is that it's so inconsistent with this other survey, which are both people describing their health-seeking behavior. The numbers for intensive care are higher, and the number for hospitalization, of course, are also higher, roughly in the same proportions, because the only major difference between these two estimates is the denominator of assumed number of sick people. And you can see very large differences by age as well, especially in fatalities. You can see that the 5 to 17-year-olds were the least likely to die if they were infected. The adults were the most likely to die if they were infected, and that's true by either measure, but especially by this measure. Yeah?
I'm just struck by how different those estimates are. In some ways, it's a phone survey not asking. Is it a phone survey at the bottom as well?
Yeah.
Asking the same
No,
question.
I think it's mostly a person survey. It's not the same question. It's a different question, actually.
Is it not saying if you had influenza-like illness, did you seek help?
So in the phone survey, they just said to people, they called people at random on the phone and said, all throughout the city, were you sick during this period? And I think they did ask if they sought care and got a similar answer, but we didn't use that particular question. So it's just, were you sick? The lower one, the CDC surveys primarily were surveys where they went to areas where there was an outbreak. So there was a Delaware College campus, and there was I think there was something in Illinois. There were several outbreaks, and they had also done this in normal seasonal flu. And they found people and said, were you sick with flu-like symptoms? Yes or no? And among those that were, did you go to the doctor? And among those that said yes, they were sick, about half of them said they went to the doctor, between 40 and 60%. And that seems to be true almost everywhere you ask. New Zealand's done a survey like that. Other people have done these surveys. About half the people say they went to the doctor. But if you try to figure out the number of medically attended cases based on the Milwaukee and New York data, and then double that, you get a much lower number than you get if you just ask people in New York how many.
Does that consultation rate change during the pandemic? So early in the pandemic, people were nervous, more likely to consult. Later in the pandemic, more blasé, less likely to
Probably so, yeah. And so I think probably more other estimates are sort of converging around here than around here. I'm inclined to think that this was probably a good guess at the denominator, even though it has its flaws. I should say, I mean, these are different. They're different by about a factor of 7 for this one, and about a factor of 9 here, I think. Considering that it started with sort of 4 or 5 orders of magnitude of uncertainty, it's an improvement. But this is, I think, sort of where the uncertainty still lies. I don't think anyone would say with absolute certainty that it's one or the other.
Was the lower rate of elderly mortality because of previous exposure to the flu, some other flu strain, or this is much lower than the seasonal mortality? Is that right? The seasonal flu.
It's a very complicated question. So first of all, you should note the confidence intervals,
Yes.
particularly on this estimate, and on this estimate. So we were dealing, the numerator here was 50 deaths in all age groups. So when you break it down by age groups, you start to lose precision. But as you'll see, the lower rate among the elderly is not as lower as you think. So let me show some other data and remind me if I don't come back to that, because it's an important question. So that's sort of the one bit of our group's research that I want to talk about today, and then I'm going to talk more now about some of the sort of issues of decision making. So given that it's hard to figure out how bad the epidemic is, especially early on, I think that means that successful planning is to include a range of scenarios that are plausible, but beyond what you think is the most likely. So a milder scenario, and also something that seems worse than what you consider the most likely. And that you really have to plan for all of them. This issue came to a head in August and September when there was a report issued by the President's Council of Advisors on Science and Technology working group on H1N1, which I was a part of, and which had a scenario in it which had between 30 and 90,000 deaths in the United States from this. 36 is sort of roughly the number estimated for a typical seasonal flu, with much variation from year to year. And it looks, as you'll see, as though it probably turns out to be a bit less than 30. There was a lot of criticism of having these broad ranges and including numbers that some people thought were implausible. The UK was actually using the equivalent of 90,000. They have a smaller population, but the equivalent of 90,000 was the lower end of their planning scenarios. So it was not the most crazy number one could imagine, but it was a number that many people thought was exaggerated. And it said 5 different places in this report. This is a scenario that should be planned for, not a prediction, because we actually don't know what's going to happen. And finally, Eric Lander, who was the co-chair of this group, made the point well, which is that essentially you have to be prepared for a bad scenario, and that's not the same thing as predicting a bad scenario. You have to be prepared for a hurricane to devastate New Orleans, but that's not the same thing as saying it's going to happen at this particular time. Yeah.
Well, you've been talking a lot about the death rates and predicting that and mortality, but one of the other things I guess that comes to my mind is the attack rate. And certainly and there was a fair amount of discussion about the attack rate. If the attack rate is X percent and the death rate is 1%, you end up with, so the attack rate is to some degree related to the impact, and the attack rate also has obvious direct economic impacts on the country as well. And so could you comment about some of the thoughts about that?
Yeah, so I think part of why this has turned out to be milder than many scenarios, including that one, is that the attack rate is lower than historic. It appears to be lower than historic pandemics. We had no serologic test, and in fact, there still hasn't been serologic data from the United States released. There's been some from Hong Kong and the UK. So we can only guess in the US, one local study here. So all you could do was base on history, because there was really no data, and history would have said at least 50% more people would be infected than were. It's maybe on the order of 20%, and historically it's been more like 30. I'll show you some estimates in a second for historical. So that's part of why it turned out to be milder than expected, and it also turned out that the lower end estimates for severity per case were more accurate. So here's one early effort by a group in Europe to estimate the impact on excess mortality. These are excess mortality figures in different years showing the impact of flu seasons. This is age group 0 to 4, 5 to 14, 15 to 64, and over 65. And this flu season was earlier than typical flu season. So this is the fall wave in Europe. And you can see that it was a substantial and worse than typical flu season. There are only 3 others plotted here. Worse than typical in the fall wave in Europe for these 2 age groups, and certainly no worse and possibly better than an average year for the over 15s. So in terms of comparative mortality, but of course these scales are different. Kids don't die very much, and adults die more, especially adults over 65. So this is 25,000, and this is 150, and this is 80. So compared to a normal year, it's clearly worse for kids than a normal year, and probably better for most adults than a normal year. But that's only one measure, so let's hold that thought for a minute. As these data have come out that suggest that, in fact, the severity was overall relatively mild in many age groups, there has been a lot of activity, mainly in Europe, very little in this country for reasons that I don't really understand, but mainly in Europe, led by the Council of Europe and this guy Wodarg, who's a member of the Council of Europe, and then a recent article in the British Medical Journal arguing that essentially, so both of them have argued that essentially this was cooked up and exaggerated by the WHO and by people working for the WHO, consulting for the WHO, who had pharmaceutical ties, essentially to sell vaccines and drugs. And this, of course, is a very serious accusation. I think it's a wrong accusation, but it's been made and created a lot of controversy, mainly in Europe. Harvey Feinberg, our former dean, is now in charge of the WHO Inquiry Commission that's evaluating these questions. I think that's a good choice because he will be very, very complete and thorough and also sober about it. But so this is the tenor of the discussion in some places. But there are other perspectives in which it maybe looks a little bit worse than the initially fairly mild impression that many people have had. This is an analysis by a group at the NIH, taking estimates from the CDC and others of the total number of deaths, and these are all adjusted to the 2000 population, and comparing it to the 3 previous pandemics and to a typical a typical H3 season. H3 is the worst of the 2 seasonal flu A strains. And what you see is that the number of estimated deaths is on the low end of certainly of H3 season, and even at a normal of an average flu season. But that the average person who died was younger, certainly than in seasonal flu, and in fact than either of the 2 previous pandemics, but similar or a little bit older in the 1918. So that if you assume that people who died had a typical life expectancy for their age, which probably is wrong. Probably the people who died were sicker than the average, had pre-existing conditions, which meant they probably didn't have as many years to live as a typical person. But if you make that assumption, you can estimate a number of years of life lost, again, all normalized to the same size population, and you see that compared to seasonal flu, it's probably somewhat worse. Compared to the previous pandemics, it's probably milder, but not necessarily much milder in terms of years of life lost. Yeah.
In the 70s, we had another, back then it was called swine flu.
Yeah.
So we had a previous epidemic of swine flu, H1N1. How does this data compares to that data from the 70s and 90s?
So that was a non-epidemic. It was an epidemic in one military base, and then it fizzled, and nothing happened.
Okay.
So there were 40 million people vaccinated, and a lot of response, and nothing happened. And that was very much in people's mind. Harvey Feinberg became famous in part for writing the book about that event. He was very often consulted about how we could avoid, his whole book was about how not to repeat the mistake of massively overreacting. It was very much on people's minds, but there's no comparison because it was only one military base. Another perspective that was really striking as this unfolded is that the perception of severity can change so much from the period of planning in anticipation of an event to the period of response to an event. In other words, the notion of what's mild is a relative term. So in answering your question about attack rate, it's thought that roughly speaking, about 20% of people get flu every year in a bad seasonal flu year. That around a quarter of the population got ill in the 1957 pandemic, about 30% in 1918, and almost 40% in 68. We don't think even 30% got infected this year, so that includes the people who weren't even ill. So the estimate is considerably further down now in terms of the number who were ill. But that was unknowable at the start of this. There was no data, and could have been no data on how many people would get it, because it hadn't happened yet. And the risk of dying per case was somewhere on the order of a few tenths of a percent in the two recent pandemics, and a couple of percent in the 1918. So, as I said, 90,000 by late August was considered to be a alarmist scenario for this pandemic, but is in comparative terms milder than either of the other previous two pandemics. And when this little graph was made a few years ago by the Federal Health and Human Services, the purpose of it was to provide a framework for planning. And the planning was, what would we do in terms of isolating and quarantining ill people and their contacts? Should we close schools? Should we suggest people stay home from work, etc.? There were 5 categories of pandemic severity, ranging from 1, where none of these were recommended, up to 4 or 5, where essentially you would try everything in your power because it was such an emergency. And categories 4 and 5 were 1918-like. Category 1, the upper end of Category 1 was 90,000. So this was considered essentially a pandemic not worth noticing. And these were considered pandemics worth serious reaction. But, so in planning, sort of nobody paid much attention to this. And in particular, nobody paid attention to the fact that it would be really hard to figure out that you were in this range early on, because the data wouldn't. I mean, if people are dying all over the place, it's very easy to tell. If they're not, and it's a question of whether 1 in 1,000 or 1 in 10,000 are dying, it's really much harder to figure out. So that was one of the many aspects that weren't very carefully thought through, because really the focus was on planning for a much more severe pandemic. When you get to the point of having tens of thousands of people die, even if it's only 1 or 2 tens of thousands, and a lot of those are children, suddenly the fact that it could have been hundreds of thousands or a couple of million is no longer really relevant. People see a public health problem, they want to solve it, they want to prevent it, get vaccines out, etc. And so the response had scaled up as if this could be a very much worse pandemic. But it was much harder to say, well, it's only going to be a few thousand kids. We don't need to worry about that. That's not an acceptable way to think about it. But in some sense, that was the view prospectively. Another aspect of severity that's worth mentioning is that we really have no idea what happened in the developing world. We know that it was that the very crude indicators of mortality that we have didn't go way off the charts. If you look at demographic surveillance site data where it exists, you can't eyeball it and say there's the flu pandemic. So we know that it was not an absolute catastrophe, but we don't know how much worse it was than here. This is the data from November. The World Health Organization in all of Africa had about 15,000 cases and about 100 deaths. 13,000 of those were in South Africa. They were almost all in white South Africans, because those were the people who were getting medical care and getting confirmed. So we know that this is a completely unrepresentative set of data. There's the WHO in the last week or so has been trying to figure out how they're going to make an estimate of the overall global burden. And the data are scarce. It's going to be a really challenging thing to do. One point that I think is worth at least thinking about as a very crude way to approach it is to consider the fact that we know that antivirals save lives in this pandemic, or we have very strong evidence. I guess it's not, we don't know it, we have strong evidence that people who got early treatment were better off. And we know that a lot of people had very intensive ICU, long-term ICU treatments, which to a first approximation in many parts of the developing world applies to almost a zero fraction of the population, a very tiny fraction of the population. So if you imagine that many of those people who were in ICU in the United States would have been fatal cases elsewhere, you get a factor of about 4 or 5 relating the severity here to the severity elsewhere. It's not how you should do epidemiology, but having seen the other ideas for how to make these estimates, there aren't any good ways to do the epidemiology. So it's at least one way to get some sort of perspective. One good thing about having, I mean, there are a lot of good things about having a mild pandemic. It was one of the good things is that it was a stress test for our vaccine system, and it showed that it doesn't work. This is an estimate of the overall national pattern of the pandemic, and this is the number of vaccine doses delivered to the US population as a percent of the population. Shift this over about 2 weeks, at least, probably 3 weeks, because it takes probably about a week to get it from delivery to in someone's arm and another 2 weeks to get immunity. So really, the 5% mark was reached right about here. So we just can't produce it fast enough, and that's clear. I think many people realize that as early back as May or so, that a very likely time for a peak of the fall wave would be right around late October or early November. It happened actually in mid-October, and we just weren't ready. The most optimistic projections were that this curve would be shifted 3 or 4 weeks back or forward, but that still would have been pushing it, and certainly the actual performance was not good. So a couple of other perspectives on this issue of age groups that you asked about. One thing that's been true in all 3 of the recent pandemics in the last 100 years is that they kill more young people than seasonal flu. So this is the percentage. Lona Simonson, a really good flu epidemiologist, did this study 12 years ago, and just plotted the percentage of the excess deaths that are in people under 65 in pandemic years, and then in years between pandemics, another pandemic, years between another pandemic, and the years since. And you can see that in recent years, essentially all the excess deaths, more than 90%, are in people over 65. In the most recent pandemic, it was almost 50-50. In this pandemic, in 57, it was about a third in people under 65 and 2/3 in people, sorry, a third over 65, 2/3 in under. And in 1918, it was all in people under 65. There weren't very many people over 65 then. So pandemic years are worse for young people than non-pandemic years.